I hope all of you are doing good. Uh, as uh, as every time the CLSI CLSI M100, the new version releases, me and our team we try to bring out an update and discuss with all of you. So this time, surprisingly, CLSI update came much before than last couple of years. Usually, it comes in the month of March or April, but this time it came in January and itself. So there are a few changes, a few updates in CLSI M100. But what we will do is we will have the session where the CLSI updates of for 2025 we will discuss. Along with that, we will give you an outset on the recent changes in CLSI in last 2-3 years, so that even if you are not aware of few of the updates of last year, you will be able to
I think it hanged a little. Vinu, are you able to listen to Sir's voice?
No, Dr. Ketan, I think it just stopped a bit. I think it's trying to come in again.
yeah, I am back. Ketan also is available, no? Yeah.
Yeah, I'm here, sir.
Yeah, so uh, with me, my team members are Dr. Ketan, Dr. Vinothini, and Dr. Charumati. So Dr. Ketan was there in Jipmer. He has worked with me for uh, 2 years plus. He has done his fellowship in hospital infection control, and that was the time where we have worked to make the antimicrobial stewardship book. Uh, we have written in his tenure in Jipmer, 2020 September to 2022 September. Uh, so, Ketan, I welcome you to the session.
Thank you, sir.
Dr. Charumati is the successor of Ketan in Jipmer. So after Ketan has finished his tenure, Dr. Charumati has joined here and she has completed her PDF in hospital infection control. So now she has finished from Jipmer and she has gone to uh, uh, Kolar Medical College, and unfortunately, today morning she had got some emergencies, so she is currently not available for the session. Otherwise, she has been a uh, outstanding contributor to this CLSA event for last 2-3 years. So after Dr. Charumati has completed the course, the next successor is Dr. Vinothini. She is currently pursuing PDF in hospital infection control. So she is available with us. So I welcome you, Dr. Vinothini.
Yes, sir. Thank you, sir.
So we will start the session. So Ketan, you can uh, present the slide.
Yes, sir. I'm doing it.
Participants, you have any questions, you please post in the chat box, and we will be continuously replying to that in the chat box.
Okay, so we are going to start on the session, sir. Can
Yeah,
you see my screen?
yes, I can see your slides.
Okay, so We all know, good afternoon, everyone. So as we all know, every year CLSI comes up with a update. It's an annual update for M100 document. The other documents of CLSI are not so fortunate enough. They get their updates, but that is usually at more than annual intervals. But this CLSI M100 is the fortunate document to have annual update every year. As sir rightly told, we got this update very quickly this year, and that's the reason we are having this session on the updates. Sir also mentioned that instead of just discussing on the updates, we'll try to touch upon the important aspects of the CLSI document, some last few years update, so that those who have a little revision or a little brush up of the last few years update. This year's update, usually we mark it as the 35th edition update. So before I begin the discussion on updates, there's a very nice concept what used to exist for in CLSI. This we used to call that system as group system. Okay, so CLSI divides its breakpoint into various organism groups. We also call that to be a breakpoint group, and CLSI has introduced the concept of cascade reporting in a very nice manner in 2023, when instead of the words group, they divided the antibiotic panel of a particular organism group into various categories. Like we all do our reporting in routine as first line agents, second line agents, third line agents. Similar way to follow the cascade reporting concept, CLSI also has brought up this tier system. It has been introduced in 2023 and it's going on. So how CLSI divides these tiers? They divide it into tier 1, 2, 3, 4 in the increasing order of their cascade. So how CLSI describes these tiers? They describe tier 1 as those agents which are supposed to be tested primarily. Means on the day, suppose on day 0, we got a sample and we cultured it on a plate. On day 1, I got the culture growth. Once we have a culture growth, right on day 1, if we do testing of some particular antibiotic, that is what we call as primary testing. So as you can see, all the primary testing belongs in tier 1, 2, 3. So as per CLSI, the testing of tier 1, tier 2 and tier 3 agents must be done on day 1 of the colony. When you get the colony and you're going to put it, you have to do testing for all tier 1, tier 2, tier 3 agents. But what about the reporting part? Reporting may you have to do cascading. So testing, we don't do cascade. But reporting may we definitely follow the cascade. This is how things go, because we don't want to delay the testing part for a particular antibiotic. Now, tier 1 agents are those which we report primarily. Once we do the testing on day 1, we see the susceptibility next day. And if the tier 1 agents are susceptible, we report them as such. Tier 2 and tier 3 agents, we hide back if our tier 1 agent has good number of antibiotics susceptible. In case tier 1 agents all are resistant, then we go and start reporting tier 2 agents. But we hide back the tier 3 agents. If our tier 1 and tier 2 all are found to be resistant, then we move ahead in our reporting and we start reporting our tier 3 agents. So this is the rule of cascade. We report the the higher generation antibiotic or higher tier antibiotic only when the lower tier antibiotics are found to be resistant or cannot be given in a patient. Then we have a tier 4 agent, which we usually do the testing only when the clinicians ask for it. The most classic example of clinicians request for a particular testing is if they want to use, suppose a ceftazidime, avibactam and astronam as a combination in certain selected patients, they want to give to a particular patient. Then if they request that in this, what you have reported is all resistant kind of drugs, we want to give this combination in this patient, can you give us the susceptibility? Those kind of testing and reporting we do on request. That is what we call as tier 4 agents. Various factors like unavailability of most of the drugs what we report susceptible, they want some other antibiotics, epidemiological profile, polymicrobial infection, and etc. etc. Then we have a category what we call as urine only category or U category. These are drugs which are tested as a routine, but they are tested and reported only in urine specimen isolates. Then we have some investigational and other antibiotic. What is the meaning of investigational? It means that the breakpoints which are developed by CLSI, the breakpoints are investigational, or the antibiotic for which the investigational breakpoint is there, that antibiotic for that organism group is not a very certified or very literature proven antibiotic as an action. So either the breakpoint is not very robust literature wise supported, or that particular antibiotic is not very robust literature wise supported for that group of organism. The breakpoint initially it's categorized as an investigational breakpoint. Then we have other. So other is very crucial, because what is other for CLSI? It means those drugs which are not which for which the breakpoints are robust. Therapeutic utility of that drug is very robust for that organism group, but that somehow that drug is not recommended by US FDA to use in US. So those all categories are others. So this is the main tricky part. So for what may be others for them, that may be a very crucial drug for us. A classic example is ceftazidime. So many cases में ceftazidime is others or cephalosporin is others for US FDA recommendation wise or CLSI wise, but for us they are a good antibiotic. So we can very clearly and very safely incorporate the other antibiotics in our testing panel. Investigational, we have to be little thinking, because investigationals, either the therapeutic utility of antibiotic is not ascertained, or the breakpoints are not very robust. So investigational breakpoints we have to always consider with a pinch of salt. So this is the table. We have the CLSI. When you go into the CLSI, the initial part of CLSI has a list of tables. So knowing about which table details on what is very crucial. So the first table is table 1 series. We have 1A, 1B like that. So this table 1 series is actually information on the tire systems. Now, when I was talking about a breakpoint group or organism group, this is what I was referring to. CLSI document, especially the M100 document, they divide the organism into certain breakpoint groups. Like, what are the breakpoint groups? We can see all the individual tables are a breakpoint group. Like all Enterobacterials, which other than Salmonella Shigella is one breakpoint group. Then Salmonella Shigella itself is a second breakpoint group. Pseudomonas aeruginosa, where the species is finalized to be aeruginosa, is another breakpoint group. Then we have Acinetobacter species. All species of Acinetobacter are one breakpoint group. So suppose you are not able to speciate your Acinetobacter, you can still use Acinetobacter species breakpoint to interpret your AST results. Then BCC, Stenotrophomonas, Maltophilia, other Enterobacterias, will come to other Enterobacterias, what it mean. Then we have Staphylococcus species, Enterococcus, Haemophilus influenzae, and Parainfluenzae. So there's a list of breakpoint groups which are available, and we must report our susceptibility based on these breakpoint groups susceptibility testing. Now, this is one of the table what CLSI provides. As you can see, it is table 1A1, which deals about the tiring system of Enterobacterials, excluding Salmonella and Shigella. So CLSI mentioned is that tier 1, tier 2, tier 3 agents, and tier 4 agents. This is how CLSI mentions in all the table. Now, this tiring is primarily based on the resistance pattern or utility of antibiotic pattern as per in US places. Now, it may be different for us, our scenario. So what will advise is that using these kind of recommendations, we should prepare our own tire. Like, for example, this is the tiring what we use in our setup. All the red ones are tier 1 agents. As you can see, some of the CLSI tier 2 agents I've also kept in my tier 1 agents. Similarly, some of the tier 2 agents of CLSI I have kept in tier 2 for me. So based on yours isolates, your institute's resistance pattern or utility, you should use this as a guidance document and prepare your own tire, and that tire you can keep as panels. So these are the panels which you will be reporting as AST panels while doing the patient-based reporting. So no need to follow directly the CLSI tiering. You can modify the tires based on Indian scenarios and then use it. That would be more helpful. Now, I've already told you about table 1. Table 1 was tires of a particular breakpoint group. Then we have table 2 series. What is table 2 series? The same breakpoint groups what I've already told you. Those were tires or the arrangement of antibiotic panels. Okay. Table 2 may actual clinical breakpoints are mentioned. So same breakpoint group, the clinical breakpoints of all those groups are mentioned is table 2. So for utility purpose, table 2 series is our most used up tables, what we commonly refers to for all our routine AST purposes. The groups are exactly same as you can see: Enterobacterial, Salmonella, Pseudomonas, aeruginosa, Acinetobacter, non-species specific, BCC, and etc. etc. Now, there is one modification what CLSI has done in this 2025. It's a language-based modifications. So what CLSI, what are the various tests which CLSI advise us against? It advises against e-test. So CLSI wise, the CLSI breakpoints doesn't have recommendations based on e-test. Even if we use that and we use the MIC breakpoints for interpretation of e-test, CLSI literature not very much support e-test uses. Now, UCAS document clearly writes that the breakpoints can be extrapolated using e-test method. CLSI is not in that way, in that page. So for them, there's one method, it is MIC based methods. When CLSI says MIC based methods, it primarily means broth microdilution, and in some cases for agar dilution also. Then CLSI has disk diffusion methods. It additionally has some supplemental test and screening test. This is how CLSI classifies the tests. So this year they have given them a specific literature. All the MIC based tests like broth microdilution or agar dilution, CLSI use the word reference method for them. CLSI says that these methods are the reference methods using which any other test can be standardized. Okay. Then we have some standard test, which CLSI standard test means all those tests for which CLSI has a specific protocol to conduct the test, and using that protocol, we can perform the test reliably. So it includes all the standard test includes routine disk diffusion test, the supplemental test, and the screening test. Now we'll be wondering what are the supplemental test and screening test. So CLSI also provides a list of supplemental test. That list is given in table 3 series. We have already talked about, we have already talked about table 1, that was tire system, table 2, which was actual clinical breakpoints. Then CLSI has a table 3 series, which actually talks of the supplemental test. Common supplemental tests which are actually routinely done by us on a routine basis. The most commonest in gram positive is our inducible clindamycin resistance. We all test inducible clindamycin resistance on a routine basis. Another common test, if you do colistin susceptibility, we'll talk about it subsequently, is colistin supplemental testing like colistin agar test or colistin broth disk elution test. Then CLSI also talks about some screening test like high level aminoglycoside resistance. This we all do on a routine basis for our Enterococcus. And then we have Vancomycin screen agar. So all these tests, supplemental test, screening test, or Kirby-Bird disk diffusion test, the language what CLSI using now onwards will be that these are not reference method, these are standard methods. This was the table I was talking of. So this is the table series, which 3 series, which is mentioned. Like you can see, we have ESBLs, we have Carbapenemase detection by various methods, AmpC, ESBL, Carba-NP. We have Astronom, Septazidim, broad disk elution synergy testing. We have Colistin testings, direct blood culture broth testing, other specific tests like oxacillin salt agar, vancomycin screen agar, HLR, high level evaporation resistance, ICRs. So these are various screening and supplemental testing which are listed in table 3. It's a very informative table. We all must go through it in detail. Okay, one more thing. Now we'll come into one very common modifications what CLSI has done. We all know that till 2024, CLSI always every year they have a list incorporated in their document. That list is the warning list of antibiotic which we should not report in cases of CSF isolates, any isolate which we obtain CSF, or a case of where there is a patient having meningitis. So all those CSF isolates or meningitis cases, there are a list of antibiotic provided by CLSI which should not be reported. Usually, we all know about those lists, all those agents which are primarily used by oral route, first, second generation cephalosporins, cefoxitins, that is cefamycins, except meropenem, all the other carbapenem like doripenem, ertapenem, imipenem, macrolide, clindamycin, lefamulins, all tetracyclines to some extent. Earlier, the list also used to be including fluoroquinolones. But in this year onwards, they have removed the list of fluoroquinolones from CSF restricted antibiotics. There's a reason because even if these quinolones have poor penetrability in CSF as such in a normal meninges, but in an inflamed meninges, fluoroquinolone still attains cross the leaky meninges blood-brain barrier and still attains therapeutic concentration okay in CSF. So considering that point in mind, the CLSI has now removed fluoroquinolones from their list. The next thing to be removed from this list, possibly in coming few years, we can see few tetracyclines removed here, because this tetracyclines specifically the most minocycline and all, they are very commonly used in CSF meningitis. Very often we get patients where of Elizabeth Kingia meningitis where the only drug susceptible is minocycline. So in that cases, minocycline, the clinicians often uses minocycline to treat such infections with a higher doses. So maybe in coming future we can see these also from removed. Now coming to next table, so we have table 4 and 5. These are our quality control tables. Quality control tables are primarily, we can use these tables to make sure that whatever test we do in our lab are done correctly. So we have two quality control table series. We have table 4 series and table 5 series. Table 4 series primarily deals with disk diffusion based QC, and table 5 primarily deals with MIC based testing series. This is the test. The first two table 4 in tables, the first two 4A1 and 4A2 talk about primarily all the organisms, all the discs which we primarily use. We can cover these QCs 4A1 and 4A2 mein. Rest all are non-fastidious ones, other points. Similarly for MIC, 5A1 and 5A2 are the main tables which we always refer to look for the QC ranges of MIC based methods. Now, I would like to ask Vinothini to show us some light on specific organism specific things.
Yes. Good afternoon, everyone. Now we'll start with gram-negative bacilli. Yes. So we'll start with gram-negative bacilli. The breakpoint changes of disk diffusion and MIC for 2024 and 2025 also. Along with that, few other points which is important for reporting also we will discuss now. We'll start with Enterobacterials. Enterobacterials, we have no changes in 2025, but we'll have a discussion on SDD. So the first thing here is we have in CLSI, we have SDD breakpoints for 5 drug-bug combinations, of which 3 is in Enterobacterials. So in Enterobacterials, we have SDD breakpoints for cefepime, piperacillin, and piperacillin tazobactam. So here the first question arises. So all of you are reporting SDD for piptas in your lab? So if you are reporting SDD, then that is good. If you are not reporting SDD for PIP test, then that is a major error. Because if you can see in this breakpoint table, so we have breakpoints for susceptible, SDD, susceptible, dose dependent, and resistant. We do not have any breakpoint values for intermediate, and therefore we are not supposed to report intermediate values for piperacillin, tazobactam, or cefepime. And while we are reporting, we have to look in our report, the SDD full form has to be added, the abbreviation has to be added, because many clinicians may not be aware what is SDD. So susceptible, dose dependent abbreviation is important to be added in the report. Along with that, so if you are adding the SDD report also, we have to add the comment saying that this dosage of drug has to be given, because for cefepime, the SDD dosage will be 2 gram IV Q8H, whereas the normal dosage will be 1 gram IV Q8H. Similarly, for PIP test, we have a SDD dosage of 4.5 gram IV Q6H over 3 hours. So it is important that while we are reporting SDD, the dosage comment has to be go along with the report. So now coming to Salmonella and Shigella. So until 2024, we had until 2023 we had Salmonella Shigella breakpoints along with Enterobacteriaceae. Now since 2024, Salmonella Shigella is completely removed from the Enterobacteriaceae, and we have separate breakpoint table for Salmonella Shigella. And if you can see here, in the breakpoint table, while we are using 2023 guidelines, so all the drugs which we are reporting for Enterobacterials was can be used to interpret for Salmonella Shigella also. Whereas now, certain drugs like amoxiclav, piptas, cephalosporins, and sulbactam, all these drugs have been removed, and therefore these drugs we cannot interpret at all, and therefore the in antibiogram we cannot include all these drugs. So the drugs available for Salmonella Shigella will be ampicillin, cefoxitin, or ceftriaxone, which are equivalent agents. Then carbapenems we have meropenem, imipenem, and ertapenem. Doripenem we cannot report for Salmonella Shigella. And tetracyclines we have azithromycin, then ciprofloxacin, quatramoxazole, and chloramphenicol. Only these 8 sets of drugs we can report, whereas the other drugs which we have breakpoints in Enterobacteriaceae we cannot report, or we cannot interpret for antibiogram also for Salmonella and Shigella.
Yeah, so Vinodini, I want to add one point here. Also, we are eligible to report all these antibiotics for Salmonella. But as you know that Salmonella Shigella are usually susceptible organisms. So carbapenems and carbapenems specifically can be suppressed. So we can do a cascade reporting, and we can report only the cephalosporins or ampicillin, azithro, cipro, quatramoxazole, and chloramphenicol. Carbapenems can be suppressed.
Yes,
Okay. Piptas and magnets which were interpretable earlier, because we used to use those the antibacterial breakpoint. Now there is a separate breakpoint for Salmonella Shigella. So these two particular drugs, although you would have put Vitek for Salmonella, but never ever report piptas and magnets. Okay, so it's a change which has happened already in the last year. So it's a reinforcement to all of you that you should never report piptas or magnets for Salmonella or Shigella.
yes. So now moving on to Pseudomonas aeruginosa, we do not have much of changes in breakpoints. So we already know that we have separate breakpoints for Pseudomonas aeruginosa and also for non-aeruginosa Pseudomonas species. This is it is very important to speciate the organism, because we have different breakpoint tables for aeruginosa and non-aeruginosa. We cannot use Pseudomonas aeruginosa for the other species of Pseudomonas. So if you can see in the table, Pseudomonas aeruginosa, we have both MIC breakpoints and also disk diffusion breakpoints, whereas for non-aeruginosa species, we have only MIC breakpoints. But when we are using UCAST guidelines, only genus Pseudomonas identification is enough, because that is a genus Pseudomonas specific breakpoints is available, and it is applicable for all the species. One change which is made in 2025 is that when we are reporting cefepime, the usual dose will be 1 gram IV Q 8 hourly. But when we are reporting Pseudomonas, the highest dose we have to give 2 gram IV Q8H over 3 hours, which is similar to the SDD dose of Enterobacteriaceae. So this year we have a change in Cefepime dosage of Pseudomonas aeruginosa. It has to be given in a higher dose.
Yeah, so it is again important to have a practice of mentioning the dose in the report. Such kind of practice will definitely help the clinicians to give the appropriate dose. This is very, very important for pip test. Can you go back to the pip test slide? Yeah, so pip test slide you can see, as we have already discussed, you have to report to the clinician that pip test when you have susceptible results or when you have SDD results for E. coli, Klebsiella and other enterobacterials. If you give a susceptible result, then the corresponding dose. If you give a SDD result, then the corresponding dose. All this should be a part of your report. Your report, if your report says only SI or R, you don't say what dose to be given. At least the key antibiotics where the doses have been recently revised, clinician will not be able to know about that. Okay, and those IV infusion over 3 hours or IV infusion over 4 hours, those instructions are very, very important because carbapenems, they work excellent if you give over IV infusions. So in addition, in JIPR, what we have a practice is we not only give comment to the clinicians in our reports, but also after the reporting is over, we go add to the website and we discuss with the clinicians and we ensure that they give the higher dose to the patient. Okay, so it's not only important that you should report, but also website visit and reinforcement to the clinician.
So
Yeah,
Cefepime,
so in this table also, in this slide also, the one of the biggest mistake what we do is when we report Pseudomonas non-aeruginosa species. So as Dr. Vinothini has already mentioned, you have to ensure that that the aeruginosa table what you are using, CLSI aeruginosa table, that you use only for aeruginosa. You should not use it for other species of Pseudomonas. For other species of Pseudomonas, the other non-enterobacterial table, that table has to be used, which has only MIC breakpoint, which doesn't have distribution breakpoint. Yeah, aminoglycoside updates which happened in last year. So Vinothini, can you update on this?
yes. So in 2024, we had updates on aminoglycosides in Pseudomonas aeruginosa. So gentamicin breakpoint is totally removed, whereas amikacin, we have only urine-only breakpoint, which is maintained in 2025 also. And tobramycin and nettlemycin breakpoints we have for all the specimens. Along with urine specimens, we can use tobramycin and nettlemycin breakpoints for all the specimens. But the problem is that with tobramycin or nettlemycin breakpoint, we cannot predict the susceptibility of Genta or AK susceptibility. So Genta and amikacin we cannot use for Pseudomonas except amikacin for urine isolates.
So very, very important. Stop reporting Genta and Amica for blood isolates of Pseudomonas. Genta, there is no breakpoint only. So Pseudomonas, you cannot report Genta at all. And if it is amikacin for Pseudomonas, then you can report only for urine because it has got urine only breakpoint. So these changes are not new. These changes have happened last year itself. However, many of the departments they still continue to report aminoglycosides for Pseudomonas. You may cite that the clinicians are asking what to do, but awareness of the clinician and making them understand that the breakpoints are not available is important. Okay. And for Enterobacterial aminoglycoside updates, you have already told, is it?
Yes.
Yeah. So aminoglycoside, there was an update for Enterobacterial also in last year. So you have to report accordingly.
Now coming to Acinetobacter species. So the major change in 2025 is with Acinetobacter. and Burkholderia cepacia complex. Now coming to Acinetobacter, so there is a breakpoint revision. So in 2024, the susceptible breakpoint was more than 15 mm and now it is drastically increased to more than 22 mm. So this is very, very important to note because with 2024 guidelines, whatever is sensitive, now few of them might come into intermediate or resistant breakpoints. And there is another one important thing with ampicillin sulbactam. The dosage also we have to report 3 gram has to be given ampicillin sulbactam IV Q6 6 hourly over 3 hours.
So there is a change in the doses.
No, it's not a change. That is an addition this year.
Addition. So this doses has to be mentioned, and ampicillin breakpoint change is a very important update. Like if somebody will ask you what are the 3 important updates in CLSI 2025, then this is one among them. Okay, and the second important update also is from Acinetobacter.
Yes, the second change will be minocycline. So again in minocycline we have got the increase in susceptible breakpoint. In 2024 more than 16 is considered as susceptible and now it is more than 22. The other one thing is here in ampicillin sulbactam only the disc diffusion breakpoint is revised, whereas in minocycline both the disc diffusion and also the MIC based method both we have increased breakpoints. So minocycline more than 22 is susceptible. Whereas in MIC, there is a twofold decrease in MIC. From less than or equal to 4, it is now decreased to less than or equal to 1. And there is another one important change here. So in minocycline with disc diffusion, if the report comes as intermediate, we cannot report as such. This intermediate test we have to clarify with MIC based methods before we are reporting. And we have minocycline dosage is also added now 200 milligram IV Q12 hourly. So while reporting minocycline, we have to make sure that the MIC breakpoint is used accordingly, revised breakpoint is used, or the DD breakpoint is used with the revised breakpoints, and also the minocycline breakpoint along with the minocycline dosage also we have to report accordingly. And another one important changes has happened in Acinetobacter species. The tetracycline breakpoint is removed. Tetracycline urine breakpoint and doxycycline breakpoint is removed. Both disc diffusion and MIC breakpoint is removed. Only minocycline breakpoint is available. So the major changes in Acinetobacter will be ampicillin sulbactam and minocycline. We have revised breakpoints, and the breakpoints for tetracycline and doxycycline both has been removed.
Okay, so this slide is the most important slide of today's test. Why? Because I told you that the updates of CLSI 2025 can be grouped into major update and the minor update. So there are 3 major updates in 2025. Among the 3, 2 major updates are there in this slide itself. One is ampicillin sulbactam and the one is minocycline for Acinetobacter species. Okay, so kindly go back and do the breakpoint changes in your respective sections and make sure that you will implement this immediately after this session. Yes, Vinodini.
Now
CLSI
we
has,
will
Go to the third important thing.
Yes.
Since I am sure that the audience are not interested about CLSI in general, but they'll be more interested for what are those 3 important updates.
Yes, now we'll start with this MCQ. Which of the following is the recommended method for testing susceptibility for Burkholderia cepacia complex? So we have 5 options.
1 second. Ketan, can you go to that MCQ, please? It is not seen in the slide is not changed. Yeah, now it is changed.
So which of the following is the recommended method for testing susceptibility for Burkholderia cepacia complex? Is it broth microdilution or agar dilution, disc diffusion method, or we can use any of the above method or none of the above method? So what will be the answer for this?
All of the above, none of the above. Disc diffusion. Which one you want to answer? So again, the question here is which year CLSI I have to use it. because based upon that, the answer will vary. So, Ketan, can you write down 2024, what is the answer? 23, what is the answer? 25, what is the answer?
Nice. So in Burkholderia cepacia complex, so there is a major change in 2025. So the changes started from 2023. So in 2023, if we can see, we have breakpoints for both MIC and disk diffusion method. So in 2023, we had MIC breakpoints for ceftazidime, meropenem, minocycline, cotrimoxazole, levoflox, and chloramphenicol. Whereas we have disk diffusion breakpoints along with this ceftazidime, mino, and cotre had disk diffusion breakpoints also, right? So in 2023, so 6 drugs has MIC breakpoints and 4 drugs has disk diffusion breakpoints. Whereas in 2024, the DD breakpoints is totally removed and we had only the MIC breakpoints. This is because there was discrepancy between the DD and MIC method. The DD breakpoints were completely removed and only the MIC breakpoints were used in 2024. In 2025, if we can see, this is a major change which has happened in 2025. Both the disk diffusion breakpoints and the MIC breakpoints are totally removed and we have only ECV values. That is epidemiological cutoff values only we have. So with this, we will not be able to report as sensitive, susceptible or resistant. Only we will have a wild type or non-wild type isolates we will be able to identify. So this is a major change. So in 2025, we have ECV values for ceftazidime, meropenem, minocycline, cotrimoxazole, levoflox, and chloramphenicol. So all the MIC breakpoints are totally now changed to ECV values.
So, as I was telling you, there are three major changes. There are three major changes in CLSI R 2025. Two are from Acinetobacter baumannii, Acinetobacter species, and the third important change is in Burkholderia cepacia complex. So, Ketan, if you can hear me, can you enlighten on this slide how you would like to report? I mean, you want to report for BCC or you do not want to report? If you want to report, then how you will be reporting?
Yes. So there are ways to handle this situation.
Am I audible,
Why
Ketan?
first? Yes, sir. Am I audible, sir? My voice is. My voice is coming, sir.
Dr. Ketan, you are audible.
Ketan sir, you're not audible.
Okay, okay. Am I audible now? Okay.
Audible,
so what
yes.
I'm telling is, yes. So what I've as we already mentioned, we have removed disk diffusion breakpoints in 2024, citing that the MIC methods are the reference methods I've already discussed. So MIC methods decide the disk diffusion breakpoints. But the interpretation of disk diffusion breakpoints, this diffusion of Burkholderia cepacia interpretation was not matching with the reference methods. So CLSI stated that the disk diffusion performance for BCC is unreliable. Don't do it. Now what they have found it, we have two reference methods we have discussed earlier. We have broth microdilution and we have agar dilution. What happens with this is in BCC, the results what we obtain from broth microdilution, right? The result what we obtain, the interpretation what we obtain from broth microdilution, it doesn't match with agar dilution, and the agar dilution result doesn't match with broth microdilution. Two reference methods have utilizing the same MIC breakpoints, but they don't match among each other. That is the reason that CLSI this year has stated that because two reference methods are only not matching among each other, it's better not to perform MIC based testing or better not to interpret MIC breakpoints. If in case someone has consider among broth microdilution and agar dilution, broth microdilution is superior to agar dilution as far as BCC is concerned, but breakpoints are not available. Okay, so how to interpret that? That is the most important question. There are options to it. One more thing they say about ECV, usually in the in rare scenarios when there are no clinical breakpoints available, we may report using ECV breakpoints as wild type or non-wild type. So, but not in this case. What they suggest is if you use also as a breakpoint to report, there's an ability that will be a non-conformity, like the wild type may have a higher MIC and the non-wild type may appear to have a lower MIC. So as well as the clinical correlation, whether wild type will get treated with those antibiotic or the non-wild type. So clinical outcome to ECV correlation is not there. Plus MIC value to ECV correlation also is not very guaranteed. How to go about if we have to report? The clinician doesn't understand CLSI and the clinician doesn't understand these concepts. So if we have to report it, we have 2-3 options. First one, we report it using 2024 breakpoints. We perform broth microdilution based methods. We interpret it using 2024 breakpoint, and we write in our comment that clinical outcome may vary in these patients if based on and in comparison to the in vitro results. So if you write that kind of comment that clinical outcome versus these susceptible data, there may be a discrepancy, then that may solve the problem. The another way out to do is you start using the ECV to report as wild type and non-wild type, and then write a comment that wild type isolates are usually not having resistance mechanism, but again clinical correlation with clinical outcome may be doubtful. So both the ways, because clinician we have to report something, we can't report Burkholderia cepacia complex. The another way out is usually Burkholderia cepacia are susceptible to cotrimoxazole and meropenems. So we can, even if we don't report susceptibility and we get that this particular blood culture is having Burkholderia cepacia complex or any other specimen, we can talk to the clinical residents and tell that even if we have not performed susceptibility, but there's a very high chance that patient may respond to cotrimoxazole, meropenem or ceftazidime as such, because they are usually susceptible to these drugs. So these are the 3 approaches. We can choose to opt both. We can use 2024 breakpoint with broth microdilution with a comment that it may not correlate with clinical outcome. We can use our ECVs, current ECVs, reported as wild type with a comment that clinical outcome may vary. Or third, don't report the susceptibility, just report the organism with a comment that usual choices of antibacterial therapy includes cotrimoxazole, meropenem, and ceftazidime to treat these infections.
Yes,
These are the ECVs.
Yes, now we'll move on to Stenotrophomonas multifila. In Stenotrophomonas, we don't have any changes in 2025. So the changes were made in 2024 only. So MIC and DD breakpoints we have for levofloxacin, cotrimoxazole, minocycline, and cefiderocol. Whereas we have for ticaracillin, clavulanate, and chloramphenicol, we have only MIC only breakpoints. And one important comment here is both levofloxacin and cotrimoxazole, they should not be used as a single drug therapy. So whenever we are reporting, this comment is very, very important. Levofloxacin and cotrimoxazole combination drug is effective, whereas monotherapy, it is not effective. And in 2024, there was a change in the susceptible breakpoint. So from 2023, more than 19, the susceptible breakpoint is increased to more than or equal to 26. So the latest update for Stenotrophomonas will be in 2024. Minocycline breakpoint is increased to more than or equal to 26. Similarly, the MIC, there is a drop in MIC from more than or equal to 4 to less than or equal to 4 to less than or equal to 1.
Yeah, and one more update which has happened in 2024 for Stenotrophomonas is the one more update which has happened in Stenotrophomonas in 2024 is the ceftazidime. The breakpoint was available for ceftazidime earlier for Stenotrophomonas. But 24 onwards, the breakpoint for Septacetin was removed. Okay. So Vinodini, you can continue.
Yes. So other non-enterobacterials, there are no major changes in 24 or 25. So here one clarification is here. So other non-enterobacterials includes all the organisms, all the gram-negative organisms except Pseudomonas aeruginosa and Acinetobacter species, Burkholderia cepacia complex, and for all the organisms in M45 where we have breakpoints. So apart from that, all other organisms, gram-negative organisms comes in other non-enterobacterial. For example, if we get Elizabeth Kingia species in blood culture or Achromobacter ralstonia species, so whenever the pathogenicity is certain for those organisms, we are supposed to use this other non-enterobacterial breakpoint. So yes, with this, the gram-negative updates is complete. Now we'll move on to gram-positive organisms.
Whether the slide movement is slow. Okay, so thank you. Now we'll talk about Staphylococcus. So nothing major has changed in Staphylococcus as such, but few tits and bits changes are there. But still, we'll try to make you familiar with those. One terminology what CLSI has introduced this year is what they call as SOSA, that is Staphylococcus other than Staphylococcus aureus. This is a terminology which they have introduced, replacing the earlier term as Coagulase negative Staphylococcus. I personally believe it is a good move, because when you try to communicate the word cons and try to make them the clinician understand about this meaning, but the first question they ask is, what is Coagulase negative? What is Coagulase? Why we are discussing a biochemical test performed in the lab as in here. So this is a confusing term, Coagulase negative, to a treating physician. So this SOSA word is a more acceptable word, like we talk about non-cholera vibrio. So the word itself talks non-tuberculous mycobacteria. That explains in itself that what we are excluding from. So similarly, all Staphylococcus which are other than Staph aureus is a good well move to use in place of cons. And now coming to some basic points about Staph aureus. One point is, once we are performing any test, which especially the cefoxitin disc diffusion, which we routinely perform in our laboratory, the temperature of the incubator where we keep the MHA plate should be maintained strictly at 35. Any variation from this temperature, usual acceptable is plus minus 2. But any variation from this 35 on either side may affect your methicillin resistance. So if you start having any problem with cefoxitin disc diffusion correlation, the first thing we have to look for is whether the temperature of my incubator is sharply maintained at 35 or so. Then there is a variation in incubation temperature for various antibiotic for Staphylococcus. Like for example, when we talk of cefoxitin disc diffusion test, the usual incubation for Staph aureus is 16 to 18 hours. That's an overnight incubation. But for all SOSAs, for all Staphylococcus other than Staph aureus, we usually keep we interpret. Even if we read the plate, so writing, if you perform susceptibility testing of cefoxitin disc diffusion for SOSA, writing timing on the plate is another crucial small change which we can implement in our routine, so that we know that what duration of incubation that plate has underwent. Are we reporting it as at 48 or early? If early, then we should really look into the plate at 24 hours of interval. Now, one more change, one more point about SAF is, if we test for oxacillin or vancomycin through any dilution-based method, we usually provide them with an extended incubation. So testing for oxacillin and vancomycin by any dilution-based method, we give usually a full incubation of 24 hours instead of the routine 16 to 20 hours of incubation. Now, this is one major change which happened in 2024. Usually, as a classic teaching, we tell that whenever you put linezolid for Staphylococcus by disc diffusion, the reading has to be done as transmitted light. But since 2024, CLSI has changed this. They say that no, linezolid plate on a disc diffusion for Staphylococcus can still be reported as, should still be reported as in reflected light. Not as transmitted light. This is a last year's change, but it's a crucial change which we must be known to our resident, because we used to be classically teaching transmitted light staph linezolid since long. Now this is very crucial. Detection of MRSA in staph. This nice table is given in table 2C of Staphylococcus, which depicts the utility of all the methods which we use for detection of MRSA. So, or MRS per se. Methicillin resistance. We have a number of tests which we can do on cefoxitin. We have some number of tests which we can do on oxacillin. So if someone asks you, name one test which can be performed only when your diagnosis is confirmed to be Staph aureus. Otherwise, you cannot do it. So that test will be oxacillin salt agar. Oxacillin salt agar test is recommended only for aureus species of Staphylococcus. It cannot be performed for other sources. Okay, so it is the speciation of Staph aureus based on slide or tube coagulase or whatever method you use. It has to be done before we utilize oxacillin salt agar as a diagnostic test. One test which can be implemented for all the species of Staph aureus will be oxacillin MIC based test. Oxacillin broth microdilution is one such test which can be very reliably used for any species of test. Cefoxitin disc diffusion usually is the most commonest test we perform, but cefoxitin disc diffusion has its limitation for 3 species. One is pseudointermedius, another is Schleiferi, and this year a new species is added in this list is Staphylococcus coagulans. So if your identification is at that level that you identify these 3 are the species of SOSA we are dealing with, then we don't use cefoxitin disc diffusion in such cases. Suppose you don't speciate your cons, then what to do? If you don't speciate your cause, then you can use cefoxitin disc diffusion. You don't, even if for some of these 3 species it may be unreliable, but still you can use, if you don't speciate on a routine basis your cons. You don't use automated systems to speciate your cons. Okay, vancomycin, one important point is that vancomycin, you just have to remember that the breakpoint which we use for Staph aureus and the breakpoint which we use for SOSA are different. The susceptible breakpoint for Staph aureus is 2, while the susceptible breakpoint for SOSA is 4. Linezolid breakpoints and tidazolid breakpoint change has occurred in the last. This was a major update last year that the linezolid for all Staphylococcus, the breakpoints were revised and it was good revised in the disc diffusion. So as lots of isolates which used to be susceptible earlier because the breakpoint was quite low in disc diffusion 20 only, subsequently landed up in intermediate or resistant zone. So this was a major update last year. I hope everybody would have revised their reporting on the revised 2024 breakpoint by so far. Now, this is one concept we always discuss. All this is primarily important for those centers which use cefoxitin, oxacillin testing using Vitek. So Vitek usually gives us a oxacillin MIC value and also gives us a cefoxitin MIC value in terms of cefoxitin screen. So when you have parallel oxacillin cefoxitin value, two permutation combination can occur. You may have a scenario where both are susceptible. You may have a scenario where both are resistant. In that cases, it is too good. Nothing to be done. Usually susceptible ones are very carefully reported as MSSA and the resistant ones are MRSA. Usually these kind of MRSAs are MEK-mediated MRSA. The problem occurs when there is a discrepancy between cefoxitin and oxacillin, especially in systems like automated automated AC systems like Vitek and all. If you have a discrepancy, a susceptible result on oxacillin, but a resistant result on cefoxitin MIC, a resistant result on oxacillin, but a susceptible result on cefoxitin MIC, then what to do? How to go about these kind of discrepancy. This is, as far as Vitek is concerned, this discrepancy is all those users who you have Vitek, you all know that this is the very common thing. We often see cefoxitin screen positive, that is resistant cefoxitin, and oxacillin having a susceptible MIC with a AES modification of interpretation as R. This is very common for Vitek automated AST system, but Vitek also has a very flaw in this. The cefoxitin screen result of Vitek is actually very unreliable. So what we have to do in such situation? Very easy. Even if you don't have a routine disk diffusion testing, you must have an option to perform cefoxitin disk diffusion and oxacillin screen agar. All those such discrepancy results, you must perform cefoxitin disk diffusion and oxacillin screen agar as a tiebreaker test. And depending on the cefoxitin disk diffusion result, you can decide. Suppose in this scenario I'm talking, suppose my oxacillin MIC, which is a reliable MIC for Vitek, and cefoxitin disk diffusion comes out to be S. So now we have S cefoxitin and S oxacillin. I'll report it as MSSA in my patient specimen. Suppose cefoxitin disk diffusion also comes out to be R. So now I have a situation where I am sure that cefoxitin is resistant by both the methods and oxacillin is susceptible. So how it's possible? Is it possible? The answer is yes, it is possible. It is possible in MRSA due to MAXI mediated. Oxacillin doesn't pick MAXI. So oxacillin is a poor test to detect MAXIs. So all those cases where your cefoxitin MIC by Vitek, cefoxitin disk diffusion by also gives resistant, and your oxacillin MIC is S, you might be having MRSA MAXI, and patient reports should go as MRSA only. This also is possible if you verify it that oxacillin MIC is resistant and cefoxitin. This is very rare. We don't get it usually from clinical specimen, but theoretically possible. These are BORSA, borderline oxacillin resistant Staph aureus. It is possible. Very rare, but possible. Now coming to Enterococcus, Vinu, you want to say some light?
Sir. Yes, sir. So now coming to Enterococcus, we have no major changes in 2025, but still there are some important points to be discussed for reporting of vancomycin. So vancomycin for Enterococcus, one important thing is it needs a full 24 hours of incubation. We cannot incubate for the routine 16 to 18 hours as similar to other drug-bug combinations. So vancomycin for Enterococcus, it is always 24 hours incubation. And other one thing is the reading has to be taken in transmitted light. And more than 17 is considered as susceptible. And one important thing here is if the zone is sharp and the zone is more than 17, then we consider that as susceptible. If the zone is hazy or if there is any growth within the zone, then even if it is more than 17, then we consider that as resistance only. So more than 17 is a susceptible breakpoint. But if the zone is sharp, we take it as sensitive. If the zone is hazy or some growth is present in between, then we call it as, we label it as resistance. So this is about vancomycin Enterococcus. And coming to the high-level aminoglycoside resistance. So here the drug what we use for testing is 120 microgram of gentamicin disc instead of 10 microgram routine gentamicin disc. So that doesn't mean that for the patient treatment, we have to increase the dosage. So once this 120 microgram gentamicin disc is found to be susceptible, so then we can use gentamicin along with other cell wall acting agents like penicillin, ampicillin or vancomycin to have a synergistic effect. And the drug, the gentamicin what we are using is the normal dosage of 5 gentamicin and it is not an increased dose. Only the disc what we are using to test high level gentamicin, the dosage is the dose is increased to 120 microgram. But for the patient purpose, the dose is the normal dose what we are using routinely. Then the other one thing here is for the HLAR testing is recommended only for serious enterococcal infections like bloodstream infections or meningitis. For the routine urinary isolates, testing of HLAR is not required. And the intrinsic resistance of Enterococcus, as we all know, aminoglycosides, cephalosporins, macrolides, clindamycin, and cotrimoxazole, these are intrinsically resistant to Enterococcus and these should not be reported. So this is about Enterococcus. So Enterococcus, we don't have any 2025 changes. Now moving on to Streptococcus pneumoniae. So here also we do not have any changes in 2025, but a few points we'll discuss. We have MIC only breakpoints for 3-4 drugs. So like penicillin, amoxicillin, amoxiclav, cefoxitin, ceftriaxone, cefepime, and carbapenems. We have only MIC breakpoints, and therefore the distribution we should not perform for all these drugs. Coming to the and certain other drugs have MIC breakpoints along with DD breakpoints like oxacillin, macrolides, clindamycin, tetracycline group, and levoflox, moxiflox, cotrimoxazole, vancomycin, linezolid, chloramphenicol. So all these drugs have an additional distribution breakpoints along with MIC breakpoint. Here, if you can see for Streptococcus pneumoniae in tetracycline group, we have tetra and doxy breakpoint, but minocycline we do not have any breakpoint for Streptococcus pneumoniae. And very important point is we have separate meningitis and non-meningitis breakpoint for few of the penicillin and cephalosporin group of drugs, beta-lactam. So drugs like parenteral penicillin, ceftriaxone, cefoxitin, and cefepime, we have meningitis breakpoint and have a separate non-meningitis breakpoints. And therefore, whenever a patient we isolate Streptococcus pneumoniae from a CSF sample or from a blood sample in a patient who has meningitis features, we are supposed to report with meningitis breakpoints only. And drugs like amoxicillin, amoxiclav, and ceftaroline, we have only non-meningitis breakpoint. So this is one important thing about Streptococcus pneumoniae. We have separate meningitis and non-meningitis breakpoint. And for patients with meningitis or with features of meningitis, we are supposed to use meningitis breakpoints for the beta-lactam drugs like penicillin, ceftriaxone, cefoxitin, and cefepime.
Okay, so as very rightly told, when you look into the Streptococcus pneumoniae breakpoints, clinical breakpoints, these breakpoints are mentioned in table 2G. Once you go to these breakpoints, you can see, like for example, one snapshot I have kept. You can see it's written as penicillin parenteral non-meningitis and penicillin parenteral meningitis. When you see into the breakpoint, you can see the meningitis breakpoints are very low. The susceptible breakpoint for meningitis is less than equal to 0.06. However, the non-meningitis breakpoints are much higher. So it means that for non-meningitis, for actual non-meningitis, treating a patient with meningitis, you need an isolate to be having more lower MIC. Then only you can safely treat those patients. So there's a extrapolation rule which is suggested in CLSI. What's that? So suppose your MIC is for penicillin is susceptible for meningitis breakpoint, that is less than equal to 0.06 microgram per ml. In that case, for meningitis cases, penicillin can be reported as susceptible, and other BLIs can also be reported as susceptible using the extrapolation from penicillin susceptibility. But if the MIC increases beyond that, as you can see, the meningitis cases may resistance starts from more than equal to 0.2. So if the resistance or breakpoint starts for meningitis cases, in that case, we report penicillin as resistant, but we can test for other beta-lactams using an MIC-based methods and report them individually. What are the common, in the last slide we have talked, what are the common beta-lactams we use for reporting in meningitis cases? Those are ceftriaxone, cefotaxime, cefepime, and meropenem. These are the other than penicillin, the other beta-lactam drugs which we usually report in cases of meningitis. Now, what if the patient is a non-meningitis patient? What is meningitis, non-meningitis? Also subsequently. But if the patient is a non-meningitis case, then penicillin can be reported susceptible if it is less than 2. As you can see, this is the gap where non-meningitis cases may still susceptible, and other other beta-lactams have to be tested separately. Okay. There's one, but not all centers are capable to do penicillin MIC based test for pneumococcus, because the Vitic card ST03 is unreliable. E-test is the most reliable. E-strip based test is the more reliable method to perform these, but if it's costly and you're not having it, you still can report penicillin susceptibility. Here the testing of surrogacy comes. So we all know that oxacillin 1 microgram disc are available. If you do disc diffusion testing using oxacillin 1 microgram, at least penicillin susceptibility can be correctly predicted. So how the rule goes? So if you test by oxacillin 1 microgram disc by normal disc diffusion, and the zone of inhibition you got is 20 or more, then we can safely report penicillin as susceptible, and as well as other beta-lactams like ceftriaxone, cefotaxime, etc. But if the zone becomes less than 19, then nothing you can do. You have to perform MIC based testing separately for penicillin as well as beta-lactam. So penicillin susceptibility can be predicted using oxacillin. Penicillin resistance cannot be predicted by oxacillin 1 microgram disc diffusion testing. For that, you have to go with reference MIC based testing method. Now, let's try to understand this concept, what we're talking, meningitis and non-meningitis. So there are two terms which we use. One term pertains to clinical scenario, and one other term pertains to clinical breakpoints. The breakpoints that we talk, penicillin has two breakpoints, meningitis breakpoint and non-meningitis breakpoint. Let's try to understand this. What is this clinical scenario and what is this breakpoint? So when you get a Streptococcus pneumoniae from a CSF sample on culture, the interpretation, and you test by MIC based method, the interpretation of those MIC values have to be done only using meningitis breakpoint. And one interpretation has to be given, SIR, whatever, but one interpretation has to be given when your isolate comes from a CSF sample. Next, suppose what about isolate is from some other specimen, be blood, like blood. So what we do is, the first question we have to ask is whether that patient is having features suggestive of meningitis clinically. Like for example, patient may have symptoms suggestive of meningitis, which may be noted down in the HIS. You can see them. Patient may have undergone biochemical analysis of CSF with raised protein, low sugars. Cytological findings may be available in the report. The count should be higher than 100 with predominant neutrophilic infiltration. So all those things indicate towards a feature of meningitis. In that case, what we do is, so if there is a feature suggestive of meningitis, we'll be interpreting those MICs only using meningitis breakpoint. One interpretation, one report. What if when we looked into the clinical presentations, we looked into the biochemical analysis and cytological findings, it looks like we are not clear, or we don't have this history. We don't have any option to get this history. So it's not clear or not available. In that case, whatever MIC we get for penicillin, ceftriaxone, cefotaxime, all those, we'll interpret using both meningitis and non-meningitis breakpoints separately. And my report will have penicillin meningitis resistant, penicillin non-meningitis susceptible. So I'll provide two interpretations separately in the patient report when I'm not sure that it is meningitis or when no history is available. If history is available, suggestive, or if it's a CSF isolate, I'll just report penicillin meningitis or whatever the interpretation is. There's a third scenario also. What if the biochemical properties are absolute normal? Cytological finding also suggests it's not a bacterial meningitis. Clinically, patient is totally fine. What to do next? In that case also, we'll use both meningitis and non-meningitis. Suppose a blood isolate where patient is not having features of clinical signs of meningitis. The CSF biochemical and cytological analysis is fine, normal. Still, we'll do the interpretation using both meningitis and non-meningitis program. You'll have a question that why so? if there's a clear-cut non-suggestive meningitis, why don't we interpret only using non-meningitis breakpoint like we did for meningitis cases? The answer is because today, when the sample was collected, the patient may not have a infiltration or a crossing in the blood-brain barrier to the CSF from blood, but subsequently in next few days or subsequently during the course in the hospital, the patients can still, this organism can still cross the blood-brain barrier and cause meningitis subsequently. So even if it's a very clear-cut non-suggestive meningitis, interpretation should be from both. And when we talk to the clinicians, we should also talk in this way, that if you suggest meningitis, just trust on whatever I reported as penicillin meningitis. If patient is not meningitis clear cut, for the time being, you can use those drugs which are non-meningitis susceptible also. Okay, now we'll move to the next Streptococcus. Dr. Vino?
Yes. So now we'll start Streptococcus. Coming to beta-hemolytic Streptococcus group. So we have no major changes in Streptococcus also, but few points we will discuss. In beta-hemolytic streptococci, we have breakpoints. That breakpoints has to be used for large colony of pyogenic strains of group A streptococci, that is Streptococcus pyogenes, group C, group G, and group B Streptococcus agalactiae. But for Streptococcus aeruginosa, which is a small colony variant, though it is beta-hemolytic strain, we are supposed to use the breakpoint of viridans streptococci. So this is about the beta-hemolytic streptococci. And viridans streptococci, we have disc diffusion breakpoints available for many drugs like cefotaxime, ceftriaxone, cefepime, erythroacetro, clindamycin, tetracycline, levoflox, chloramphenicol, vanco, and linezolid. But we have only MIC breakpoints for two drugs, penicillin and ampicillin. This is to be noted. In viridans streptococci group, penicillin and ampicillin has only MIC breakpoints. So other important point here is, since these organisms produces a larger zone, we can use only four discs in a 100 mm plate. So usually we'll use six discs, whereas in beta-hemolytic streptococci or viridans group, we can use only 4 discs. And ASD plate, what we are using is MHA with 5% of sheep blood agar. We cannot use Newton agar, which is supplemented with 5% blood. It is Muller-Hinton agar, which is supplemented with 5% sheep blood. So with this, we are completing GPC and GNB updates. Now we'll move on to direct diffusion from positively flagged blood culture bottles. So since 2020, we have this direct blood culture broth disc diffusion method. So here we have only few changes we have. Before moving on to the changes, we will see the salient features about this method. So what we can do is, instead of waiting for a 24 hours colony, directly from the blood culture broth, we can take 4 drops of blood and then we can do a routine ASD. But this method has to be done within 8 hours of lagging positive using a 20 gauge venting needle, and the incubation period will be 8 to 10 hours to a maximum of 16 to 18 hours. Okay, so these will be the important points here. The points to be noted here is, within 8 hours of lagging positive, we have to do this DST testing, and we have to use 20 gauge needle and 4 drops of blood culture has to be taken. And the interpretation of results can happen in 8 to 10 hours or 16 to 18 hours. So we'll move on to the methodology. So we'll have a brief procedure discussion. So once the bottle is flagged positive, so you'll take out the bottle, you'll just mix it thoroughly, and you'll sterilize the top of the bottle with an alcohol wipe. And then you take 4 drops of the blood culture broth using a 20 gauge needle, and then you place it onto an MHA agar plate and you do the usual lawn culture. So the technique is the same. So you are going to do a lawn culture at 180 degree for 3 times, and then you're going to place the discs on the medium. And incubation, here you can incubate for 8 to 10 hours, and you can take it out and you can see if there is a visible zone, then you can interpret the results. So if you're not able to see the zones properly, then you can re-incubate to a maximum of 16 to 18 hours. So CLSI, we have 2 different breakpoints for DST. One is at 8 to 10 hours. The other one is at 16 to 18 hours.
Okay. So Now, what are the various antibiotics for which breakpoints are available for this direct susceptibility testing using positively flagged blood culture? This is a summary table which you can also prepare in your setup, and just if you perform DST, prepare something like this and stick it to the wall of your lab. This will help us you to prepare a panel of DST. Like for example, these are the drugs which are used, for which breakpoints are available for direct susceptibility testing for Enterobacteriaceae. We have in total 7 such drugs, out of which Cefipaim breakpoints are recently added in 2025. This is one update. Cefipaim breakpoints were not present, DST breakpoint were not present for Enterobacteriaceae till 2024. Then coming to Pseudomonas aeruginosa, we have similarly 5 drugs for which DST breakpoints are available. And for Acinetobacter, we have 8 drugs for which direct susceptibility breakpoints are available. Piptas is a new addition in this case. Piptas DST breakpoints for Acinetobacter was not present so far. I have just color coded this for easy understanding of my reference purpose. Is that as you can see, the green color coded I have made it as these are the new entries which are included only in 2025. These are the updates in 2025. Then the blue ones are those which for which the breakpoint has changed. We have already discussed that Acinetobacter, AmpC clinical breakpoints have also changed. So in par with this, they have also CLSI has also updated the DST breakpoints, which is same as what it is for routine. Then we still don't have a 8 to 10 hour breakpoint for Cefipaim, Pseudomonas aeruginosa, and cotrimoxazole enterobacterials. Normally, we have a concept that we think that the breakpoint which is supposed to be generated using a 16 to 18 hours of incubation of a positive flag blood culture, a broth, uh, is same as a colony overnight AST plate. Normally it holds true, but there are certain scenarios where it may not hold true. I highlighted in this table, I highlight those as yellow ones. Normally, I will repeat, normally a 16 to 18 hours zone diameters, breakpoint zone diameters for a DST, is usually same as the colony Kirby-Boas disc diffusion breakpoints, clinical breakpoints, not in all cases. What are these all cases? Like for example, meropenem and ciprofloxacin in Enterobacteriaceae, the DST 16 to 18 hours is different from the colony 16 to 18 hours. That holds true for ceftazidime in Pseudomonas aeruginosa. That holds true for ceftazidime in Acinetobacter. Again, we normally have a notion that 8 to 10 hours DST breakpoints is supposed to be smaller or different from 16 to 18 hours colony AST, but that is not the case. There are a list of breakpoints for some drugs where the 8 to 10 hour breakpoints is also same as what we use in colony susceptibility. So this is just a table. You all can prepare this kind of table and take a printout of it and stick it in your labs for further quick reference for your DST panels. This is the table, how the table is given you. As we already told, for this Enterobacteriaceae table, for every drug, there is a 8 to 10 hour breakpoint and there is a 16 to 18 hours breakpoint. You can also mention the colony AST breakpoint wherever it is not matching. Take a printout of it and stick it in your file or in your workbench for quick references. Now, this is something which is introduced this year. So they have introduced a sort of quality control for DST. I use the word sort of because this is not actually the strict quality control for DST. The purpose of this is, what they did is usually some or the resident or the training staff, they have to read the plates in an early growth. They have to read the plates at 8 to 10 hours. The colonies are not very clear cut. The zones are not very obvious. So you have to train yourself to read an early plate. So this kind of training of reading of early plate can be standardized using these QC ranges. So CLSI this year has introduced 3 zone ranges for DST for these ATCC strains. One is BLBLI QC strain, another is the routine QC strain, E. coli and Pseudomonas ATCC. So we can use these ranges. So if you put E. coli ATCC with ampicillin and read it at 8 to 10 hours, the ranges should be in between this range. So this is how, using these ranges, we can train our residents or train our staff to make sure that they do early reporting of the plate at 2 to 10 hours with minute colony, fainter bands more correctly. And it can always be standardized, it can always be matched with their performance to read our routine QC strain, colony AST with this is also a colony. These strains, these isolates are not spiked on blood culture bottle and then done. This is a colony reference strains, but only the reading is occurring at 8 to 10 hours instead of reading it next day. So we can read the same plate at 8 to 10 hours, match it with these ranges, and subsequently we incubate it more 6 to 8 hours and read it with our routine QC ranges. This is the purpose of these tables, just to train the staff and make them more familiar with reading a less obvious growth on a MHA plate. Now, little changed during the QC testing. They one change last year, the Colistin QC ranges for E. coli was removed and Pseudomonas was updated. So now if you do CAT and CBD test for Colistin, we cannot use E. coli ATCC for these purposes. We have to use only Pseudomonas aeruginosa ATCC strain to standardize and to QC for our CAT and CBD. This year they changed the ranges for only E. coli ATCC for minocycline. Earlier it was 90 to 25. Now these changes are 2026. Why these changes we are telling you? Because if you maintain a QC, you must update your document and include your newer QC ranges in your document to be some language based modifications they have done, not very usually. Wherever they were using daily and weekly as an option, now instead of using weekly, now CLSI has started using a term individualized quality control program. Means whatever the individual institutes have decided for their center, they can follow that plan. So it's just a cosmetic change. Now, one more thing they have come up is, I've told you about table 2 series. Table 2 series is actual clinical breakpoint for each breakpoint groups like Enterobacterial, Salmonella, Shigella, Acinetobacter, everything. So earlier, when every such table used to start with a recommendation on the QC. Okay, now the CLSI has omitted that part and they are telling you simply refer to the QC documents. QC ranges given subsequently. I told you table 4 is for disk diffusion, table 5 is for MIC QC ranges. Don't recommend group specific QC recommendations. They simply tell us to follow the tables given in table 4 series and table 5 series. I personally feel this to be a very important change, because this will prevent us to go through a huge lot of confusion. I'll tell you, similarly, they have done for all the tables. I'll tell you what was the confusion which I felt was that this change is very warm welcome change. So suppose I'm putting, I use amikacin disc in my institute for testing against Enterobacter routinely. So if I follow the earlier recommendation and go through those routine QC recommendations from Enterobacterials, it looks as if I have to test for the QC of amikacin disc if I am testing for Enterobacterials. If I am using that amikacin for Pseudomonas aeruginosa, I have to use this ATC strain, but that's not the case. Actual case was, when we go to the table 4A, we see that QC of amikacin of strength of 30 micrograms by either of these 3 QC strains. We can use Staph aureus, Pseudomonas aeruginosa, or E. coli ATCC, or a combination of it, a combination of these two, or a combination of these two. can be used using this table. So this confusion whether to trust this recommendation or whether to trust this table 4A recommendation was the earlier confusion. The same holds true for MIC things also. Now things are very clear cut. What QC strand to test for a particular disk or particular dilution based test, you simply have to go to table 4A and table 5A series and use those ranges. Now I'm coming to some spatial resistance in gram negatives. I'll just maybe you may be familiar with these points. So what I'm trying to just bring into your notice is a little points about these drug resistance phenotypes of a gram-negative organisms. First, I'll talk about AmpC organisms. How we'll deal with AmpC organism. We all, some of our labs will be testing AmpC on a routine basis in the lab for during routine disk diffusion. Many of us don't do it. So do we need to do testing? Do we need not to do testing? This is a very confusing. It's a never-ending discussion. Okay. When we do the testing, what is recommended? The recommendation is the standard testing should be done with a double disk disk diffusion test, a combination disk diffusion test. We have to use a combination of testing with cefoxitin and cefoxitin cloxacillin. And if cefoxitin cloxacillin zone minus cefoxitin zone is more than equal to 5 mm, these are what we call as AmpC producing organisms. If you do, this is the standard way. This is the only standard way which we can do on a routine basis, easily done AmpC detection. But the point is, do we need to do it? The answer is, if I have to clinically divide significance wise, I have to divide AmpC organism. I divide it into high AmpC producers or clinically significant AmpC producers. These are only these 3 organisms: Enterobacter cloacae complex, Klebsiella aerogens, and Cytobacter frundi. These are known AmpC producers. So no need to test for AmpC in them. Once these organisms are isolated in a clinical specimen, we know that it is going to produce clinically significant AmpC. So AmpC detection in these 3 organisms are not required. We know they are clinically significant AmpC producers. What we mean by that, patient reporting wise, what we mean by that, these AmpC producers, as far as beta-lactam susceptibility is concerned, they are usually resistant to first and second generation cephalosporins. Third generation cephalosporins are usually resistant, but in vitro you can get susceptibility of third generation cephalosporins. Okay. But when you treat these patients with these organisms, these 3 organisms which I listed, with a third generation cephalosporin in patient, these organisms develop quickly resistance in even 1 to 2 days or 3 days of therapy only. These organisms may develop resistance. This is what we call as inducible AmpC production. So what to do, how to go about? Should we report? Should we not report? There's a way to do it. The first option is that if you get these isolates, don't report your third generation cephalosporins, don't report your piptas, don't report your astronome. This is one way out. Just skip that. Don't report them resistant. Don't change the report from susceptible to resistant. Skip it. Don't report. Start your reporting from cefepime and meropenem and non-beta-lactam antibiotics. Okay, this is option 1. You can choose to do this, or you can choose to do option 2. You report as per the AST. Whatever the AST came, you use the interpretation, you use it, but make sure that your clinical team send the repeat sample after 48 to 72 hours to look for subsequent development of resistance. If you can't ensure that they'll be sending sample after 40 to 70 hours for development of resistance, then option 2 is not feasible for you. Otherwise, you can report, you can ask them to treat also. Just that repeat testing is compulsory. If repeat testing is not feasible, don't report. Cefepime best is to report. Cefepime is often susceptible, but again, perform the susceptibility and then only report cefepime, not just without testing. You should not report. If cefepime comes out to be resistant in these organisms, don't report them susceptible. Testing is important. For rest all organisms other than these 3, do take a call. Okay, because they are not clinically significant, so you can report safe without any AmpC testing in them. So even if you don't do AmpC testing other than these 3, you can safely report based on your AST breakpoints. That is what CLSI says. In AmpC testing and changing the breakpoints is not required. Interpretation is not required if you use the existing breakpoint. This was about AmpC. ESBL detection, do we have to do? Do we not have to do? In case you have to do, then we use same combination disk diffusion test. We use ceftazidime clavulate combo disk, or cefotaxime clavulate disk, or both. If you ask me among these two, if I have to do only one, which I should choose, the answer is ceftazidime clavulate disk, which is supposed to be preferred over the other one. Okay. Now this is the statement which I have copy pasted from CLSI. Clearly says that if you test using current breakpoint, do not change the report from susceptible to resistant just because you have picked up an ESBL in your testing, be it molecular testing, be it phenotypic testing using it. Changing the report from susceptible to resistant to third generation spoilings is not required at all. Be safely, you can interpret using breakpoint and report it as such. Now, Carbapenemase detection, there are lots of write-up in the last year also, and the write-ups for Carbapenemase detection have increased in CLSI. They are paying more attention now towards Carbapenemase detection in Enterobacterials. So I'll tell you very quickly what they are talking. So do we need to do Carbapenemase detection in Enterobacterials as a compulsory means? The answer is no. Compulsorily to report Carbapenem as SIR. No need to do Carbapenemase detection testing. Simple. Okay. If you get Carbapenemase, suppose you do Carbapenemase testing and you get Carbapenemase detected, don't change your report from S to R. Interpretation can be done safely using the breakpoints. Okay. But why we need Carbapenemase detection? Carbapenemase detection testing has a different purpose. Okay. I'll tell you about the subsequently what is the purpose of doing Carbapenemase detection. Okay. What are the methodologies we have? We have Carba-NP test, which is not very useful. We have AmpC and ESBL. Sorry, I missed the M and E. My mistake. So AmpC alone not going to help you out. You can go around with AmpC and ESBL combination, but it serves a limited purpose. What CLSI write that if you do a Carbapenemase detection testing, better to do it with a method which can detect the type of Carbapenemase. What Carbapenemase we are telling. Mere information on serine versus metallo-beta-lactamase is a half work done. Okay, better to have a test which can pick on individual gene types. If not, then at least a differentiating between serine and metallo-beta-lactamases. So picking on the type of Carbapenemase is very important. Okay. One important point is how to go about if there's a mono resistance in Carbapenem. Okay, like for example, you test for imipenem, meropenem, and ertapenem. Ertapenem comes susceptible or resistant, which is not matching with your meropenem result. Suppose meropenem is susceptible, erta is resistant, erta is susceptible, mero is resistant. How to go about these things? So CLSI has a nice table which I'll show you the screenshots of those table. You can simply read through those tables and use your own what we call as institute policy to decide that there is no hard and fast rule on these things. You have to make an institutional policy what to go about. I'll show you those tables. They are very interesting tables which you have in CLSI, must be read through. Now, what about susceptibility to if your carbapenems are resistant, you have carbapenemase detected. Whether to report, can we report safely cefepines? Can we report safely third generation cephalosporins? Answer is, for a patient's purpose, better to skip those. Better to not report a susceptible result of third and fourth generation cephalosporins when you have a carbapenemase producer. It's not possible that the answer is yes, it is possible, but the risk of reporting a wrong third generation or fourth generation susceptibility with a carbapenem resistance in Enterobacterials it's better to skip than to report a very major error or a resistant and having a patient failure in therapy. So it's safest to avoid reporting in Enterobacteriaceae. I'm talking non-fermenters may like Pseudomonas and all may. You still can take a courage to report that. Enterobacteriaceae is, if you have cephalosporin susceptible and Carbapenem resistance, better to skip on you verify your Carbapenem results. First thing is go to look for purity. See that yes, my isolate is pure. Repeat the Carbapenem susceptibility to find out that whatever I have picked as a Carbapenem resistance is actually Carbapenem resistance. On a repeat testing, if you still get the same, then avoid reporting third generation or fourth generation as susceptible in those Carbapenemase producers as well as Carbapenem resistant organisms. Now, I was telling about purpose. So can we do Carbapenemase testing or should we do in our setup? The answer is very simple. If newer BLBLI are available in your setup for therapy, if your center has access, your patient have access to newer BLBLI for a therapeutic choice, then Carbapenemase detection is a must for you, because the choice of your subsequent therapy or a newer BLBLI therapy is guided by the type of Carbapenemase you pick. Like serine has a different therapeutic option. Metallo-beta-lactamase has a different option. Whether newer BLBLI like meropenem, Weber-Bactam and all will work for your patient or not, it will all be decided by the nature of Carbapenemase so detected. So if you have newer BLBLI available in your setup for therapeutic uses, Carbapenemase detection you have to do, and preferably by either a combination of AmpC and ESBL, and best is to do a gene level detection among the top 5. Another important part about Carbapenemase detection is when you have a variation in the Carbapenem susceptibility, like one Carbapenem is resistant, another is susceptible. In those cases, looking for Carbapenemase makes sense. Because depending on how the Carbapenemase result is coming, you can decide on whether to suppress the susceptible report or I can rely upon that and report. In general, the concept says that if you have discrepancy between one resistant and one susceptible Carbapenem, if Carbapenemases are found, Carbapenemase producer, try to suppress the susceptible report. If Carbapenemase are negative, then monoresistance can occur through efflux pump and pouring channels. Then you can safely report one as susceptible and one resistant. Few notable exceptions are one is imipenem and triproti. Triproti, all organisms, Proteus, Providencia, and Morgana are expected to have a higher MIC of imipenem. So very commonly you give imi-resistant and other Carbapenems are susceptible. Same holds true for Enterobacter cloacae and Klebsiella aerogens. Artapenem resistant and imi and mero susceptible is quite common. So in those cases, monoresistance maybe we can safely report others as susceptible. But otherwise, if that's not the case, better to do a Carbapenemase positive Carbapenemase testing, and based on its result, you can decide whether one Carbapenem susceptible and other Carbapenem resistance I should safely report or not report. Okay, one change what they have done this year is, I'll just focus on the change. We all know about AmpC and ESBL methodology. Earlier, what the interpretation of ESBL and AmpC CLSI used to recommend, that if your AmpC is positive and your ESBL also comes out to positive, you tell that to be a metallo-beta-lactamase producer. If your AmpC is positive or your AmpC is negative, then we used to call it to be a serine Carbapenemase. Okay. Now CLSI is not telling that, and they are very rightly doing it. They have picked that error and they have addressed it in this version. Why so? Because suppose your AmpC is positive, your ESBL is negative. This can be either due to a single expressing serine Carbapenemase. That's why ESBL or EDT is not giving you good zone. If you have a coexisting MBL and serine Carbapenemase, in that also, this MBL you'll miss. You'll think it to be only serine Carbapenemase and you'll falsely report it as that metallo-beta-lactamases are not present. But not the case. It will still have coexisting MBL and SCP. This was a major issue with the last year's report, but very correctly they have picked it. So that's why they have used the term inconclusive. So if your AmpC is positive and your eSIM is not giving positive, means it's a negative test, we call it as inconclusive. You have to find out alternative way to pick on MBLs. You have to use some other test, molecular based test or some lateral flow assay test. But that test you cannot rule out ki MBLs are not existing. We can have coexisting MBLs, and that will alter your therapy. That will definitely create problem while you use your newer BLBLIs. Okay, so this is a major change what they have brought it in this year. Okay, these are the tables what I'm telling. You go into table appendix G, and in appendix G you have table G3. Once you go into G3, there are many scenarios which they have given. Okay, and these are the to read very nicely. These are very interesting scenarios what to do. But again, I'm telling you, these are not hard and fast recommendations. Understand the concept behind they are talking like this, and then formulate your own policy. They should all be institutional policy, how you go about with monocarbapenem resistance, how you go about with carbapenem resistant and third generation, fourth generation susceptible results. What you do in your setup is to be decided by your institute after going through these recommendations. But I definitely I'll request you to go through this G3 table ka read. These are very good. Now I'll ask Dr. Vinu to move ahead with tetracyclines.
Yes. So coming to the clinical points of breakpoints of tetracyclines, we don't have major changes. Only we have some cosmetic changes. One main change with tetracycline is that for Acinetobacter, tetracycline and doxycycline breakpoint, which was previously present in 2024, is now removed. That is a major change. Apart from that, all of the things are only cosmetic changes. So the table this we have made is to ensure that for different organisms, we have breakpoints for different tetracycline group of drugs. If we can see, we have minocycline only breakpoints for Neisseria meningitidis. So we have only minocycline specific breakpoints. Tetra and oxy we do not have. Similarly, if you can see for beta-hemolytic streptococci and Streptococcus viridans, we have only tetracycline breakpoints. Doxy and minocycline we will not have. And Streptococcus pneumoniae, if we can see, we have tetra and doxycycline breakpoint, and minocycline breakpoint we don't have, and minocycline this tetra breakpoint we can extrapolate only to doxy, and therefore for Streptococcus pneumoniae we cannot extrapolate or use clinical breakpoint for minocycline. So this is about tetracyclines. Coming to the extrapolation rule. So in 2024 and 2025, almost the same concept is discussed, only the language is a little modified. So in 2024, the same thing was there, like if it is sensitive for the group of organisms like Enterobacterial, Salmonella, Shigella, Acinetobacter, other non-enterobacterials, and Staphylococcus. For these group of organisms, if sensitive to tetracycline, then it is considered sensitive to doxycycline and minocycline also. The same thing is maintained in 2025, except for a few language change. And if it comes as resistant or intermediate to tetracycline, then it has to be tested with doxy and minocycline separately if these drugs can be or required for treatment, right? So this is about these major group of organisms. Similarly, for Haemophilus group of organisms and Streptococcus and Neisseria gonorrhoeae, if it is sensitive to tetracycline, then it is considered sensitive to doxy and minocycline. But here the major thing here is if the organ isolate is Streptococcus pneumoniae, if it is sensitive to tetracycline, then it can be extrapolated only for doxycycline. We do not have minocycline breakpoint also, and therefore tetracycline group of drugs we can have breakpoints only for tetra and doxy. Tetracycline can be extrapolated only to doxy. Minocycline we cannot extrapolate, and we do not have breakpoints for minocycline also for Streptococcus pneumoniae. Right? So this is about tetracycline and extrapolation. Now we have two more things to discuss. One is about the Ceftazidime avibactam astrionum synergy testing. So whenever an organism is MBL producing organism, then we are supposed to do this Ceftazidime avibactam and astrionum synergy test. This is because astrionum can act against the metallo-beta-lactamase organisms But the thing is, all the MBL producing organisms usually co-produce ESBL and AmpC also. And therefore, if you are giving aztreonam as a monotherapy, then this aztreonam will not be effective because of the ESBL and the other enzymes which is co-produced. And therefore, we are adding ceftazidime avibactam to the treatment regimen, because this ceftazidime avibactam or the avibactam component will protect the aztreonam from the ESBL and AmpC producers. Okay, so this is the basic behind this synergy testing. So,
one thing I like to add is usually this synergy testing of ceftazidime, avibactam, and aztreonam, I like to classify them into two types. One is what I call is that qualitative synergy testing, and one is what I call as quantitative synergy testing. What is quantitative synergy? When in the presence of ceftazidime avibactam, primarily avibactam, the aztreonam reaches its clinical breakpoint, its susceptible breakpoint. I'll again repeat, when in the presence of avibactam, if aztreonam reaches its clinical susceptible breakpoint, this is kind of synergy is what we call as quantitative synergy. For a patient reporting purpose, it's always advocated to use a method which will give us a quantitative synergy, means with which we can predict the aztreonam susceptibility in terms of clinical breakpoint. Those methods are the recommended methods for patient-based testing. Now, why broth disk elution is a good test and easy to do test? Because as you can see, the concentration of ceftazidime, once we add a disk to it, is 6/4 of ceftazidime, and aztreonam, it is 6 microgram. So we test by this method the ceftazidime avibactam at these concentrations. The breakpoint of aztreonam is actually 4. So in this disc, the concentration of aztreonam is 6. If no growth occurs in this, and if no growth occurs in this, it means the MIC of the organism is less than 6, because we are testing aztreonam with 6 microgram concentration and the susceptible breakpoint is less than equal to 4. So if no growth occurs in aztreonam tube or no growth occurs in ceftazidime avibactam aztreonam tube, it means possibly the aztreonam MIC is less than 6, because 6 is inhibiting them. So it is less than 6. Less than 6 is 4 or less. So it means aztreonam has a susceptible breakpoint reached. That's why this kind of broad disk elution synergy testing can be referred to as a quantitative testing, and for patient report, always use a method which is predicting the quantitative synergy, not the qualitative synergy. This yes, please.
Yes. So now we'll move on to Colistin broth disk elution method. So in Colistin, we have two methods. One is CBD and CAT. Both are recommended by CLSI. So this CBD is very similar to that of ceftazidime avibactam synergy testing. We'll take 4 tubes, but one difference here is in CBD here we take 10 ml of broth, whereas in ceftazidime avibactam we take 5 ml of broth. But that is not a major change, because the inoculum what we add here is 50 microliter, and in that ceftazidime we will add 25 microliter, and therefore the final inoculum will be the same, right? So this is about CBD. And colistin agar dilution. So one thing here, what is mentioned in CLSI is we can test a maximum of 10 isolates, because this is agar diffusion method. So we cannot randomly put so many lines and we can test so many organisms. CLSI recommends to do only 10 isolates in colistin agar plate.
Okay, and which to choose? See, one thing you have to be very clear in your mind, that automated AST systems, Whitake or any other automated systems, colistin is not reliable. So you have to use, for correct colistin interpretation, either you use a broth microdilution method, if you can do in-house broth microdilution best, or you do a commercial broth microdilution from a reliable vendor. In-house is much better than those commercial vendors if your vendor is not reliable. Alternatively, we have a very simple method of CAT and CBD. But what to choose, when to choose CAT and when to choose CBD, my advice will be if you have a high throughput lab where the gram negative isolates you get are good number, you're like 5, 6, 10 gram negative organisms in a day, then the method of testing colistin supplemental testing use for you centers would be CAT. If you are a low throughput center that 1, 2 or 3 kind of CBD would be the correct choice for you. So if low throughput center, low GNB throughput centers, you choose for CBD. For a high throughput center, go for CAT based testing, but definitely include a supplemental colistin based testing. Don't just rely upon on automated colistin results for colistin reporting. Too unreliable. So this is a concluding slide. What we have discussed so far, major breakpoints are very limited. The most number one major breakpoint, like sir has already told, we have Burkholderia cepacia complex. All MIC breakpoints are removed. This diffusion breakpoints were already removed last year. Now only have ECV breakpoints. Now, second important is tetradoxy breakpoints from Acinetobacter are gone. We have only minocycline breakpoints available. It is a very good move because ECAST wise tetradoxy are intrinsically resistant for Acinetobacter. But CLSI still was having tetradoxy breakpoints in place. So UCAST was clearly mentioning tetradoxy as Acinetobacter intrinsic resistant drug. CLSI was having breakpoint very safely, very nicely. They have removed it this time. So happy. Now the third breakpoint, the third change is ampicillbactam disc diffusion and mino disc diffusion and MIC breakpoints both have been changed this year. In the DST breakpoints, we have some antibiotics added and fluoroquinolones have been reporting list. So these are the major changes, top 5 changes of CLSI this year. The last thing what I want to tell you is, other than these, we have discussed table 1 to table 5 in these discussions. We still have table 6, nice, very good appendices. So these are good reads. We have lots of information on microdilution, dilution of drugs, calculation of potencies. We have SDDs information, ECV informations. We have cephadurocol testing, other molecular assays reaction. So lots of appendices, glossaries, and time we can give some time to these very nice tables, very nice informative points. So that will be the end of today's CLI sessions. We tried to cover the basic updates as well as the important salient points which we must keep refreshing in our mind so that we do a correct reporting. Over to sir. Sir, are you online?
Yes, Ketan, I am online. I was fascinated by your session. We thought of a 1 hour, 1.5 hour session, but it went for longer than what we expected. For the obvious reason that CLSA is ever discussion topic. There are so many things which we learn every time we open CLSA. All is the appearance of the book is so compact, the language is so difficult that every time we read the book, there will be some new thing which we learn. So I hope the session is useful to the participants. So the key messages you want to take at the end of your session. So, Ketan, what do you want to say? What are the key messages you will give? Ketan?
Yes, sir. Let me share it. Whether my screen is visible, sir?
Yeah, your skin is visible, Ketan. Uh, so yeah, so the key messages are very clear that the three important updates. First is the breakpoint for the ampicillin sulbactam for Acinetobacter has been changed. Minocycline breakpoint for Stenotrophomonas was changed in the last year. This year they have changed for uh, Acinetobacter pneumonia also. And of course, BCC, that is Burkholderia Burkholderia cepacia complex, there is a change in the reporting format. You will not be able to report the AST because there is no clinical breakpoints are available. So it is a bad thing. It is a bad thing because it is a hospital-acquired pathogen where the clinicians are dependent on us to release the report. So it is it will be a loophole in the reporting. But Ketan, what about using UCAS breakpoint for Burkholderia cepacia complex? Is there a
We
breakpoint?
Yes, UCAST has been not having a breakpoint for many years in a row, sir. I think last 3 years, say UCAST has removed its breakpoints. They have a consensus document per se, and where they say that testing for this is unreliable, and it's been for last 3 years. It is CLSI who has introduced this concept a bit late. I feel, sir, we have three ways to do it. I'll just repeat those. Uh,
Yeah,
this is
you have
how
told this
I.
earlier also. You can repeat again because this is
Yes.
the key message what they have to know.
I feel because clinical team will be needing a update on us how and to treat the patient, those who have Burkholderia cepacia complex. The first way about is we have to do a broth microdilation based testing and use the 2024 breakpoints provided it for interpretation for by MIC based method by broth microdilution, and then write a note in the as a comment that uh, the correlation between the susceptibility and in vitro result or clinical outcome may vary. This is one way. Second way is we can use our 2025 ECV. We start reporting as wild type or non-wild type for each drug, and then we write the comment that clinical correlation of these wild type, what is wild type, what is non-wild type as a comment, and clinical correlation may vary between wild type and clinical outcome or response. The third way out is we should just report the organism name, talk to the clinical team and suggest them or write as a comment that cotrimoxazole, ceftazidime, meropenem are good and reliable options to treat similar kind of infections, and judge your whether it is acting or not or working or not in the patient based on the clinical outcome. If you start the treatment on ceftazidime and cotrimoxazole, if you don't see the response, move to meropenem or minocycline as such. So these are the step 1, 2, 3 or options 1, 2, 3. Any one of the institute can decide on their particular healthcare facility and go about from these. Yes, sir. Sir, you're mute, I think. Yes, sir. Now it's okay.
Yeah. So do you recommend reporting according to ECV breakpoint?
If you have to choose between older breakpoint by broth microdilation and ECV, I think reporting by broth microdilation using 2024 breakpoint is much more reliable compared to ECV. ECV correlation with clinical outcome is much bad. That is what CLSI suggests. Means a wild type strain may have a higher MIC and a non-wild type strain may have a lower MIC for that Burkholderia cepacia isolate. So it is unreliable. But in general, that option means for some ECV we use we have an option of using for 2024 breakpoint. So I think that will be should be the priority one.
So that is better than reporting as per ECV breakpoint.
Yes, yes.
Okay, so there are some questions which they have asked Ketan. Many of the questions we have already replied in the chat box itself. Few questions are left, so I'm asking you. You can see, you can try to give your inputs. One is how reliable is Ocni lateral flow assay for the detection of carbapenemase enzymes? What is our experience? I have not used it. Ketan, have you used in your setup? Ocneve,
Uh,
that ICT card is coming now
yes,
for
lateral
the
flow assay.
carbapenemase detection.
Yes. See, only important point is what is the purpose of using it? If your purpose is to decide whether I have to give meropenem, weberbactam, whether I have to give ceftazidime, avibactam, astronam combination, or some other newer bilbili which is available in your setup, like for example, cefepime, enmetazobactam. If the decision to test is that, then we may use these things, but with a pinch of salt. And with current newer bilbili, it is always wise to go with ceftazidime, avibactam, astronam synergy testing and use them for therapy than picking on the gram carbapenem genes and what to do next.
Yeah.
Otherwise,
So
brand
maybe
wise, Ocneve is a reliable brand. The how it actually fares, we have articles, but I don't know how much reliable those articles are.
reliability of ICT compared to gene detection by real-time PCR. Maybe
Definitely, sir, gene detection is way
better, no?
ahead
Much
of it.
better, yeah.
Yes.
But gene
Yes.
detection has its own loopholes because it takes time.
Yes.
ICT is easy to perform.
Immediately to perform.
That is where ICT wins over the molecular detection. But when it comes to accuracy, of course, molecular detection will be better. Yeah, so Ketan, you were telling about
Yes.
cefepime enmetazobactam. So there is a question about this. So one participant is asking this molecule which is US FDA approved and has a UCAS breakpoint also. Can it be reported for GNB?
Yes, it can. Definitely, it can. We have FDA breakpoints as well as UCAS breakpoints available for this molecule. So, if it is available for, again, reporting a fancy drug which is not available for patient uses in your hospital, no worth doing it. But if this molecule is available, it is in India, it is with Cipla. So, if your institute uses it, your clinicians or treating team uses it, definitely FDA and UCAS to report it on a routine basis.
Yeah. So, Dr. Vinothini, any other question which you have not replied in the chat box, you can tell me. I can ask you.
Breakpoints.
This is the
So breakpoints for DST of gram-positive organisms. So DST we
Yes.
usually do for gram-negative organisms only. For GPCs we have UCAS guidelines for certain gram-positive organisms.
Yeah,
Vast
but
breakpoints.
Ketan, you can tell our last vast experience in JIPMER about DST for gram-positive organism because we routinely do for more than 8 years in
Yes.
JIPMER.
Yes. As far as Staphylococcus and Enterococcus are concerned, we use our colony 16 to 18 hours ST breakpoint to interpret our DST results, and our experience in JIPMER is very good. On a live basis in our HIS on the software, we
Yeah,
see our
I
correlation
I
between
have one
DST and AST.
I have one submission here. For cefoxitin, it is not much reliable. Staphylococcus cefoxitin, that is for MRSA detection, as DST sometimes doesn't work well. Otherwise, in general, for gram positive, it is the correlation is excellent.
Usually the borderlines ones are where we have to be very careful. Like we have the cutoff of 22, but those which are coming in 20, 21 or that ranges 21, 23, those are the places which we have to be very careful, be MSSA or MSA turn out to be MRSA. The clear-cut susceptible and resistant ones usually don't flip out.
So any other question? Yeah, so one question is directed to me by some of the postgraduate student. When the essences of microbiology for postgraduate will be released. So I would like to say that the systematic bacteriology volume of this postgraduate book will be released soon in another 2-3 months time, maybe uh, m- May May 2025, you can say, and the rest part will be released next year. Next year or over next few years, because it is very difficult to predict how much time each volume will take. The systematic bacteriology took almost 2.5 years for me to script. So at this point of time, I can say only about that volume.
Now one participant has asked the question. What is the experience in detecting inducible clindamycin detection on DST? Did you observe any interesting finding?
ICR on DST, Ketan.
Yes, it can be. It is usually picked correctly in DST. The placement of antibiotic is, if it correct, then placement of antibiotic is the only thing we have to take care of. But it DST find ICR is picked nicely. One question is in MBL quantitative synergy test. I just very quickly tell. We'll release the video so that you can listen. Quantitative synergy test for synergy is basically any testing where in presence of AV bacterium, if astronome attains a susceptible breakpoint MIC, is called as quantitative test, and we can look into the breakpoint of astronome that whether it has crossed its susceptible breakpoint or not, like double eat strip method. It's a very good method. In presence of AV bacterium from one E strip, astronome MIC, we can read it in the E strip. So any test where avibactam presence astronome reaches a susceptible breakpoint, be it combination broth microdilution, be it double eat strip, be it broth disk elution, all methods are quantitative synergy of septa AV and astronome.
Okay. So that's all from our side. We will release this video as soon as it is available. Tomorrow, maybe tomorrow or day after, we will be releasing the video. And if you have any further questions, then you can post in the chat box, and we will reply subsequently. So that's all from our side. So Ketan and Dr. Vinothini, thank you very much for your valuable inputs. Unfortunately, Dr. Charumathi was not available. Otherwise, he has been a part of this session for last several years. That's all from our side. So goodbye to all of you, and have a fast, immediate CLSI implementation, the update implementation in your lab as soon as possible. Okay, so February 16 may be the starting point. Right from tomorrow, you can implement. Bye.
Yes. Thank you so much, everyone. Bye.